Our two crystal arthropathies today, which are very straightforward: gout and pseudogout. The premise behind gout is based on purine metabolism. Essentially, what happens is you have end products that are uric acid that's filtered through the glomerulus and it's reabsorbed at the proximal tubule in the kidneys. You get a flare when there's all these macrophages, they ingest the monosodium urate crystals, you get hyperuricemia, monosodium urate deposition, and then the reaction to phagocytosed crystals leads to baseline inflammation. Flares can self-resolve, although long-standing inflammation and long-standing gout, these actually lead to a different type of gout called tophi. And then to diagnose gout, it is that classic negative birefringence in the setting of arthrocentesis or when you look at the synovial fluid under microscope. To manage an acute gout flare, there's three things you can do. One, you can prescribe someone NSAIDs. You can treat with steroids, and you can also treat with colchicine. I typically choose colchicine for like an end-stage renal disease patient or dialysis patient. You can dose reduce that, or you can use steroids in those patients. But typically, I would avoid the NSAIDs in the dialysis or CKD patients. In terms of maintenance, you use a medicine called allopurinol. Be really cautious of that HLA-B58 genetic mutation there, because these patients will actually get DRESS. It's pretty significant, actually. I know a lot of VAs test for this genetic mutations, like 15 to 20% or something crazy. So what happens if you can't use allopurinol? Well, you can use something called febuxostat. And that is a great medication. However, you have to be really careful in those who have prior cardiovascular disease, or they have like MI, stroke, history of stroke, things like that. Now, what happens if you have a difficult control gout, maybe like 6 flares in 1 year, something like this? You can add a medication called probenecide, and that's a uricosuric agent, and it's synergistic with allopurinol, and you can also use it with febuxostat too. There's a last medication I want to talk about is pegloticase. This is it is very good for tophaceous gout. However, it's an injection, so you have to be cautious for the risk of patient getting an anaphylaxis. The gold standard diagnosis for gout is you need to see that negative birefringent needle urate crystals in the synovial fluid. And, even if you have a positive synovial fluid under the microscope, you cannot exclude infection, so be very cautious in these patients. You need to be aware that they also may have concomitant infection. You're going to treat with the 3 things here: colchicine, NSAIDs, and steroids. And then for your maintenance therapy, you want to target a goal of less than 6 for your uric acid level, and that's with the American Academy of Rheumatology. Pseudogout has that positive rhomboid-shaped crystals under the microscope. The treatment is typically the same medications that we use for gout. So NSAIDs, colchicine, sometimes steroids, sometimes you can use like an anakinra off-label. If you have 3 or more attacks annually, just like in gout, then you can start a low-dose colchicine or a low-dose NSAID for those who have pseudogout if they have 3 or more flares. Physical therapy is also a staple for these patients with difficult-to-control pseudogout and gout. And that's pretty much it, guys. Like and subscribe if you like this video, if you want more content. It really helps me build these awesome presentations for you guys, and I really enjoy what I'm doing. So if you guys find this helpful, please like and subscribe and leave a comment if you have any questions or concerns. Thanks so much for your time.